So yes, my name is Victoria Clower. I'm coming from Savannah, Georgia today. And I'm very honored just to be here in Montana. It's my very first out-of-state conference, so I'm just very blessed to be here, but I'll get straight into it. So I'm gonna be sharing some findings with you guys from my pilot WellAware program. It was for my dissertation that we looked at to use private well testing, not just to inform, which is what we all do here, but to actually motivate health prevention. So in this presentation, I'm going to share with what we found in those private wells across rural Georgia and how people interpreted and reacted to their wells and what happened when we paired testing with targeted education. So starting off, I just want to share a little bit about how this project idea came to life. So cancer in Georgia has been taking a pretty decent toll, and right now about 1 out of every 5 deaths in our state is caused by cancer, and that number is still rising. Cancer remains a leading cause of death, currently number 2. And from 2016 to 2024, we saw that Georgia had a cancer diagnosis of about 26%, and with an increase of more than 13,000 cases, and 10% increase in cancer deaths. And that continued to rise from 2024 to 2025, when the diagnosis increased about 5% and deaths increased roughly 2%, according to estimates from the American Cancer Society. And another important issue is that a lot of these deaths in Georgia that come from 4 different types of cancers, including lung, breast, prostate, and colorectal. And these are the ones that we generally have tools to detect early, and in many cases treat effectively when they are caught on time. And even though despite these high cancer burdens in this state, Georgia lags behind in screening rates, especially in southeast rural communities, and especially specifically to limited access to awareness and knowledge. So about 120 out of Georgia's 159 counties are considered rural, and that's about 75% of the state's land, and it's home to more than 2 million people. And across the Southeast Health District, including 16 counties, as seen in red on the map, only 1 is classified as urban. So that's nearly 94% of the Southeast Health District that was considered rural. So moving on, unlike public water systems, we do know that private wells aren't regulated. Testing and treatment are up to the homeowners, and that can lead to some potential exposure to cancer-linked contaminants if they do go undetected. And although we know private wells don't cause cancer, but because of the harmful contaminants that could be in these, the proximity to agriculture, poultry farms, and other environmental risks that they can be found in these types of places. So as we know, due to the things that came together from my literature and what we found in other studies, we came together to create a study that could look at how increasing people's knowledge, understanding your water quality status, and also trying to decrease and increase cancer screening in the area. We decided to come up with a study to look at more of a public health-wide aspect to environmental understandings. So we started to look at radon, arsenic, nitrate, and lead, and we looked at real barriers such as cost, of not knowing what to test for, maybe just being too busy, and really looking and bringing the conversation to them. So some of the methods we're going to go into, I want to express that these pictures that are on the slides are from the actual participant wells, and it is very common to see within 15 feet of, you're going to see some livestock. You might see poultry in the background, chickens running around. It's very common in these areas. But to explore this problem, what we found is we used a quasi-experimental pilot study with a two-group pre-test, post-test design, and we split a total of 100 participants into two groups. One group of private well owners received both targeted education and free well water testing, while the other comparison group received only the free testing, so both with 50 participants each. So this design allowed us to look at having free well testing alone, free education alone, and then the combined of them together. And we used this convenient sampling approach that looked at the roles of education on shaping beliefs, perceptions, and screening intent for the future. Alrighty. So, the educational intervention consisted of 5 town halls, like listening sessions like we're doing today, and we held them between July and October of 2025 in Tatnall, Evans, and Bullitt counties, which addressed cancer trends in their area, in their state, and disparities about cancer screening, potentially health risks associated with contaminants. We talked a lot about how contaminants can get into their wells, and we also sampled following the protocols of a registered lab in our area. So we did use a third party for that. And then we also did a pre-post intervention survey that we used online through Qualtrics platform. And we used it using the constructs of the Champion Health Belief model, adapted from those scales, as well as other questions from the HINT survey. And that consisted of 79 questions before and after every intervention. So focusing on group 1 at baseline, we did see that participants who received greater benefits of screening were about 14 times more likely to intend to screen in the future. On the other hand, lower perceived seriousness of cancer significantly reduced the likelihood of screening intent. And then after the educational intervention, we did begin to see a shift. So participants who refuted fewer barriers were almost 4 times more likely to intend to get screened, and we also saw that a higher self-efficacy or confidence also played a major role, with participants being over 9 times more likely to intend to screen. However, one pattern did remain consistent. Lower perceived seriousness continued to be negatively associated with screening intent even after education. So what this really tells us is that while education can reduce barriers and increase confidence, perceived seriousness remained a critical driver of screening intent and require a different communication approach. People may understand the risks, but if they don't believe those risks are serious, they still may not act, possibly due to them waiting to see if it applied to them in their drinking water, only after they receive their free well test. For group 2, the group that received only the free well testing, we did not observe any significant predictors of screening intent at baseline or after they received their results. At baseline for both groups, only 13% of participants had ever tested their well prior, and that's out of 100. Only 6 of those said that they tested their wells on a regular basis according to recommendations by the Georgia Health Department. And out of that 13%, only 1 person understood their well and what their results meant for human health and the long-term impacts for their family. Let's go to the next slide. There we go. So looking at the distribution of contaminants in private wells, several key patterns did start to stand out. First, radon was the most prevalent concern. The average concentration was very close to 500 picocuries per liter, which is considered slightly elevated, but it does exceed the EPA recommended level of 300 picocuries per liter for water. Some levels in wells did reach as high as almost 3,000, indicating substantial variability and potential exposure risks. For nitrate, there were 22 out of 100 wells that saw contamination. We did still see observed values exceeding the EPA standard of 10 milligrams per liter with the max of 11.48. And in this specific home, the husband did end up passing away from colorectal cancer, who had been living in this home for more than 80 years. And they did have the highest nitrate level, and he had never tested before in his life. So this was his generational parents' home. So that does suggest that while not widespread, with 22 out of 100, elevated exposures did occur, mostly around agricultural areas in this region. Arsenic and lead followed a very similar pattern, with only 6 wells indicating arsenic and 5 wells having lead. However, there were notable exceedances with arsenic, reaching up to 15.7 micrograms per liter, and lead had up to 18.15 parts per billion, well above the established EPA thresholds. So overall, while not every well was impacted, a substantial population, around 68% of households, were exposed to at least one contaminant at levels of concern. So here's where things get really kind of interesting. When we did look at understanding contamination risk, participants in Group 1 who received education were about 3.7 times more likely to intend to get screened. In contrast, for Group 2, who only received their well results, this relationship was not significant. We see a similar pattern when looking at the influence of education overall. We did see that it did increase screening by over 4 times, but when participants only received their well results and no education, there was no meaningful impact on intent to get screened. Now, one of the strongest findings across both groups was understanding water test results and what that meant for their health. Participants who said they understood their personalized results were significantly more likely to intend to get screened, nearly 19 times more likely in both groups. And even when combining them together, results still increased screening intent by nearly 5 times. So cancer screening intent increased in both study groups following intervention activities. And in Group 1, the proportion of participants reported intent to screen increased from 30% at baseline to 62% following the educational intervention, and it remained at 62% after participants received their well test results. And in Group 2, the testing only, screening intent increased from 20% at baseline to 56% after receiving well test results. But I would like to show you 2 real examples from our study, one with elevated lead and nitrate, and another with high radon. There you go. So these reports do a phenomenal job at telling people what's in their water, right? But they kind of fall short in telling people what it actually means for their health. And they use a lot of hedging language like, this may pose some health risks, slightly elevated, or may not pose significant health risk. But that can create some confusion for those who don't really know how to understand or read reports. It could create false reassurance or inaction if they don't see anything lit up or further explained. So there's, of course, no mention of cancer screening. There's no mention of follow-up with your doctor or get medical follow-up, and there's no personal health implication as well. So even though we know radon, there's a lung cancer risk, or with arsenic, there's multiple cancer risks, the report stops at the environment, but there's no further health. They're communicating exposure data, but not perceived risk. So it basically says, consider treatment, test again, or contact someone, but it doesn't really answer how urgent this is, who should I call first, what does this mean for me specifically? And that's kind of where we wanted to step in with this specific study and go take it a little further. So the standard water reports are designed around regulatory thresholds and treatment decisions. So in many cases, guidance is only provided when a contaminant exceeds a specific limit. But health risk really doesn't work like that. For example, even when lead was detected at levels below the action threshold, it was present at a very high level, as you can see circled. And from a health perspective, especially for contaminants like lead, we know it's a neurotoxin. There are no truly safe levels of exposure. Unfortunately for this report, it was not highlighted, it wasn't mentioned, and even though it was close to the 15 MCL, they didn't mention it that, oh, well, I guess it wasn't over, so we're not gonna highlight that for the well owner. So what we aim to do was bridge that gap, not just report whether something exceeded or not. We went further and helped participants understand that at any level of exposure, what that could mean for their health for short-term or long-term. So this is a little bit of an example of one of my many emails that I've sent during that study, and it was very important for me to not create fear, of course, and to connect health to meeting and provide actionable steps for them. So this partial example was specifically how I communicated results back to the participant. Our main goal was to create understanding. And what we did was we connected water quality findings to health meaning using evidence from peer-reviewed articles and other research while keeping the tone very clear. And for example, when lead for that other report that I just showed you was detected below the regulatory threshold, we didn't just say that it was safe, right? We explained to them more of what that contaminant was and how that there are no safe levels, especially they also did have a child in their home who was under the age of 5, and why that matters, especially for those vulnerable populations. And for nitrate, when levels did exceed the standard or were very close to exceeding the standard, we provided context on potential health effects, including both immediate concerns, things to look out for, and other long-term risks supported by other literature. But just as importantly, we paired that with information with actionable steps. I was able to speak with them or communicate via email for different links and provided different resources to them that they could reach out to. So the goal wasn't just to alarm them, it was more to empower them with information that they could use to decide and make better health decisions for themselves. We did have some limitations to this study, of course, I'm not 100% certain, this was an increased intent to screen. Whether they actually did screen for the future will have to have a follow-up. But of course, this was a pilot study that hoping that a WellAware program can continue, and any advice, guidance, or any information that you would like to help me on that front for the Southeast Georgia coast, of course, it is most welcome. And I'm very happy to be here and would love to take any questions. Yes. I think I have it on my phone as well. Okay. I'm just short. So how did you measure whether participants understood their water results? So that was based on the questionnaire at baseline, comparing it to a yes and no question at the end of both interventions. So like I said, purely survey-based. What materials did your team use as a reference for communicating results to participants? Yeah, we used peer-reviewed articles, and we also looked at EPA references and sources to make sure that the information we were telling them were from places that really could not, I can't find the word for it, but that they could also look up, because we would send them that information as well. We wouldn't just give them our information and just that's the fact. We would give them the information but follow it up with sending it to them as well. So many of them did ask for papers, and we were able to send it to them. or they asked for different sources that we were also able to send to them as well, from other programs to, like I said, EPA, and things like that. Hopefully that answered your question. Did you measure if participants already had water treatment systems? Yes, that was in the survey as well, of those that filtered in their home or those that have in-home treatment systems. That was a part of the survey as well. And those were, we did take that into account when doing the analysis as well. So if so, do you think these individuals had different behavior changes compared to participants who did not have treatment systems? That we did not measure, and that is definitely something that we could continue on with, how they specifically were changing from different types of. So this is a great thing about this study, is that because of the survey was so large, we could honestly go in and have those types of analysis to compare, but for this one, we did not do that. Would you have recommendations for scaling up these customized interpretations for higher sample numbers? Are you, whoever asked this, is this for like more participants? Or for like a community-wide type of conversation that you're wanting to have? Because we did it based on personalized individual homes and homeowners. So I'm thinking the question is asking for maybe community-wide.
I'm not sure either. Whoever asked it, you can just reach out.
Find me after, and I would love to answer that. I am currently in the process of publishing it, and once it is available, probably within the next month or so, Dr. Aslan has definitely been editing it currently, and once it also goes to my other committee members and they have their chance as well, we should be publishing it very soon. So thank you for that question. Were any medical professionals involved in the creation of your provided interpretation of results? No, that they were not. This was purely a behavior change type of survey and study. And like I said, this was a pilot, so this is definitely something that could grow and ask more questions about, be developed in multiple different ways for future research. I think this was very different from a lot of the private well studies that you may have even heard of, where we kind of took it a step further into an area that usually it should go together, right? But often not. It doesn't go together. But I think there's definitely room for future research to create that. For working in rural areas where funding may be lacking, if someone has contamination but can't afford a new well, did you include any information on treatment systems? When speaking with homeowners, of course, some of them were very nervous or scared about their results when they got them back. Unfortunately, we do have issues with funding and continuing the project WellAware. But I did include information on where they can find it, where they can access it, some companies that are out there in Georgia. I was able to provide information. And I did help at least one or two families that have reached out to me that wanted to fix that contamination in the well. One was for radon, and another one was for nitrate, where they did reach out to me, and I worked with them to contact other companies that had treatment options for them, and I believe since then they have treated their well. Was there any notable spatial distribution of wells high in radon? A lot of them were very close together for radon, which some research has shown that radon coming from the fall line in Georgia can be trapped in clays that we have predominantly in South Georgia, and you can have pockets of radon get trapped in those clays. And that's kind of like what we saw, that it was very different from home to home, from street to street. Unfortunately, I did not create any maps to show you due to I was not able to with the IRB that we had. But I think it was different from home to home. But generally speaking, they were in the same county. That's probably the most I can say on that due to IRB. Did you collaborate with University of Georgia at all, since they also have a well testing program? They are the accredited lab that did our testing, and we worked really closely with them and Dr. Saha at the University of Georgia. So he is the one who, and his team is the one who did all of our testing. We know that tobacco smoking greatly increases the risk of lung cancer. I wonder whether this might make a difference in seriousness for participants who were smoker. Great question. That was actually a part of our survey, whether they smoked or not, or whether they had smoked at least 100 cigarettes in their lifetime. And surprisingly, only like 2 people smoked. So it wasn't a huge issue for this study. Now, if we continued on and probably sampled the entire county, we might see something in terms of that. But for this specific one, of course, this study isn't generalizable for either county or any of the, it's just specific to the to participants in the study. So it's very small in comparison. AOR is it's adjusted odds ratio. Sorry for that, to putting that out there and not explaining that further.
That's all good. All right, so let's give Victoria a hand.